Greetings and thanks so much for stopping by. I'm Bob Brown, the developer and content manager of the Pulmonary Diagnostic Laboratory Resource Center, and will be presenting information on technologist-driven protocols, bringing added value to pulmonary diagnostic services. This is a topic that I've been passionate about for a number of years. That's why on my website, I've devoted an entire focus area addressing pulmonary diagnostic protocols. This presentation is about 50 minutes in length. I've numbered the slides on the bottom right so that if you need to leave this presentation, you can simply note where you stopped and pick it up from there at a later time. If you have specific questions not answered in this presentation, please visit the Pulmonary Diagnostic Laboratory Resource Center at www.pftlabresources.com and send them to me along with your comments. My email is located in the contact page, and I'll make all attempts to get back to you in a timely manner. So at this point in time, I have no conflicts of interest. And I was fortunate to be at the right place at the right time when I started at Northwestern Memorial Hospital, as it was a period of great innovation in the field. Northwestern encouraged employees to seek out opportunities for improvement, and I was first introduced in about 1979 to the RT-driven protocol concept while at Northwestern Memorial Hospital. It was entitled the Bronchial Hygiene Assessment Program. My previous experiences at Northwestern Memorial Hospital helped me to better understand the importance of improving upon the delivery of services provided by Pulmonary Diagnostic Laboratory while I was with University of Wisconsin Hospitals and Clinics in Madison. While not diagnostic specific, during the last 4 years that I was employed in the Vaccinology, Immunology, and Infectious Diseases Division of Merck Medical Services, I devoted a majority of my time teaching key opinion leaders on the importance of incorporating implementation science principles when developing, validating, and implementing sustainable vaccination programs. Based upon my diverse experiences and learnings, the Pulmonary Diagnostic Laboratory Resource Center was developed. It primarily focuses on methods to potentially improve the delivery of pulmonary diagnostic and respiratory care services. My careers have provided me with rare opportunities to work closely with some of the brightest and most respected researchers, clinicians, diagnosticians, and leaders in their respective fields. I'm also grateful to have had the opportunity to work with some key professional healthcare organizations on important projects whose ultimate objectives were to improve upon the delivery of high-quality care. So the objectives are outlined here today, and at the end of this presentation, the participants should be able to describe the impact of a changing healthcare environment, the importance of technologist-driven protocols, which is also known as TDPs, what's the payback for diagnostics with TDPs, decision processes used in a clinical scenario review, select implementation science, also referred to as IS concepts, and application of key concepts to the technologist-driven protocol development process. So these PubMed researches were performed on August 12, 2022, and what I'm showing here is the PubMed results versus viable results for a technologist-driven protocol. As can be seen, there were search term results for all searches. However, they were not viable. By this I mean that in a specific hit, either in the article title or the body of the abstract, either a single search word or words were included in the return. For example, for the technologist-driven protocol search, a return might be radiology laboratory protocols. Also, for the sake of time, I only reviewed up to about 250 abstracts for those terms that return numerous results. This doesn't mean that pulmonary laboratory technologist-driven protocols were not presented in a scientific session or published in a non-Index Medicus journal. For your information, PubMed supplanted Index Medicus in 2004. I also don't have institutional access to Scopus, which has a greater medical literature search capabilities than PubMed. However, if you search PubMed with respiratory therapy or respiratory therapist-driven protocols, you have numerous returns, especially during the mid-1990s and within the last couple of years. So, based upon these PubMed findings, this presentation is largely based upon personal experience with developing, validating, implementing, and monitoring technology-driven protocols, as well as research and teachings on healthcare process improvement strategies, also known as implementation science. The Pulmonary Diagnostic Laboratory Resource Center referenced focus areas which are relevant to this presentation include indications for pulmonary diagnostic testing, implementation science, and of course, technologist-driven protocols. Now, the first two areas provide the basis when designing and implementing a sustainable technologist-driven protocol program. Historically, in the healthcare arena, the quality improvement interest began in earnest in the late 1980s to early 1990s, primarily utilizing the Deming Management Model, also abbreviated as DMM. And that was developed and initiated for the rebuilding of Japan right after World War II. In essence, this Deming Management method incorporated the plan, P, do, D, check, C, act, A, the PDCA cycle to assure the quality of processes. By its design, generally a top-down approach, the Deming Management Method assumes that the initial plan, P, to be implemented was correct and that quality was assured if the implementation process was enacted, D, as outlined, and checked, C, for exactness. If the D and C aspects were not as expected, action, A, was taken, for example, retraining, and the plan was reinitiated. The PDCA cycle was followed and assessed until the intent of the original plan was achieved. While these concepts were, for the most part, satisfactory for their original intent, they proved to be limited in a fluid, dynamic environment such as healthcare. However, the DMM was instrumental in providing the understanding of the importance of developing and monitoring quality processes in healthcare. Pulmonary diagnostic laboratories have a long history of addressing quality-related issues, from quality control for instruments, quality assurance initiatives, continuous quality improvement projects, etc. However, one quality area that has not gained enough attention as it relates to the delivery of services is through the use of validated technologist-driven protocols. Regarding background, the U.S. healthcare industry is slowly, and I do mean slowly, transitioning from quantity to quality. The healthcare environment has been in a state of transformation for numerous years. Delivery of healthcare costs have dramatically increased without foreseeable substantial abatement. Now, what we're looking at here, and hopefully you can see it okay, is that what percentage of the gross domestic product, the GDP, is healthcare. If you look down on the bottom left, in 1960, about 5% of the GDP was related to healthcare. However, if you start looking up around 2018 up to 2021, the GDP is somewhere around 18.5% in 2021, and the average of 2018 to 2021 is 18.4%. So, as you can see, the amount of dollars devoted to healthcare costs have increased dramatically over the years. Additionally, the need for quality patient interventions along with provider and customer satisfaction are key drivers for change. This is going from the transition from volume-based to value-based care. And one of the aspects we're going to talk about is the quadruple aim. So let's take a look at the value-based care concept, the quadruple aim. The triple aim was developed by the Institute for Healthcare Improvement, the IHI, in October of 2007. Building upon this, the University of Arkansas for Medical Science has adopted the quadruple aim. Currently, the quadruple aim has been an impetus to assist providers in appreciating what internal and external factors may be influencing the changing healthcare setting and/or system. The quadruple aim framework areas are considered to be the drivers of today's changing healthcare system. The four cyclical components of the quadruple aim are essential and are dependent upon each other to maximize the patient and provider healthcare encounter. They are: improve the patient experience of care. This is including quality and satisfaction. Improve the health of populations. Reduce the per capita cost of healthcare. This is the transition from volume to value concepts. And improve provider satisfaction, which is associated with professional wellness. Many of these factors are key contributors to consider when detailing the importance of technologist-driven protocols to institutional decision makers. This concept will be discussed later in the presentation. Continuing with the transition from quantity to quality in healthcare, understanding what some of the components of healthcare change might entail does not necessarily translate into effectively developing and employing processes which could maximize improving the delivery of care. Therefore, the development of clinical practice guidelines, also known as CPGs, by professional organizations has been viewed as instrumental to adopt expert opinion and evidence-based information into clinical practice in order to improve the delivery of quality of care. However, translating clinical practice guidelines into actual clinical practice may be complex and therefore inconsistently implemented. Guidelines provide the information on what the right intervention might be, however, they do not provide the how to do it. Sharing common goals, and also using multidisciplinary teams to patient care will theoretically reduce redundancy and costs. They could also potentially improve upon the quality of care as well as the patient experience, going back to the quadruple aim. However, these types of activities may not be effectively developed, executed, and/or sustained due to a lack of understanding of the individual and related components which are integral to assure program success. Now, I'm referencing you to take a look at the focus area implementation science that's located at www.pftlabresources.com, as you can get a better understanding of what some of these additional concepts may be about. Transitioning to Technologist-Driven Protocols, why now? The American Association for Respiratory Care, the AARC, has begun in earnest readdressing the potential impact of evidence-based practice and how it may impact the delivery of respiratory care services. So the American Association for Respiratory Care Clinical Practice Guidelines Task Force were initially formed in 1990 with the intent of providing the profession with documents developed from evidence-based information and expert opinion that could help guide practice. After about a 10-plus year run, the Diagnostics Clinical Practice Guideline Task Force was subsequently disbanded and the procedure-related guidance was relinquished to the American Thoracic Society. Now, the American Thoracic Society Pulmonary Function Laboratory Management Procedure Manual was started in late 1996 and published in early 1998. And for those of you of interest, check out the contributing authors acknowledged in the third edition. So the next section we're going to look at is Technologist-Driven Protocols, why now? The next series of slides will hopefully provide a better understanding of how the American Association for Respiratory Care is taking action to address the changing healthcare landscape by encouraging the respiratory care practitioners to better understand and enact the concept of value efficiency within their practice. Don't worry, I'm not going to review this article. However, I'm going to cherry pick some key statements, which I've italicized or bolded, along with providing some recent American Association for Respiratory Care educational topics, which will support the importance of evidence-based practices and ultimately technologist-driven protocols. The respiratory care value efficiency concept has been a work in progress. A version of this paper was presented by Rob Chatburn at the AARC Congress in 2017, which was held in Indianapolis, Indiana, and again at the AARC Congress in 2018, which was held in Las Vegas, Nevada. And a version of this paper was approved by the American Association for Respiratory Care as an issue paper in February of 2021. So continuing with the concept of technology-driven protocols, why now? The best practices in productivity and staffing value efficiency was established as an AARC position statement effective November 2021. And once again, it talks about the increasing demands of payers, administrators, consultants, and patients on the delivery of high-quality respiratory care services. So going back to the article entitled Determining the Value Efficiency of Respiratory Care that was published by Chatburn, Ford, and Kaufman in Respiratory Care in December 2021, this article provides the philosophical rationale behind the importance of respiratory care practitioners to adopt and engage the concept of value efficiency. It's about raising the awareness of a changing healthcare environment and the potential survival of the profession. Continuing with the article, Determining the Value Efficiency of Respiratory Care, there's a general consensus on quality of patient care among those who order treatments and those who provide those treatments, and ultimately those who pay for those treatments, because purchasers will continue to express a desire for more value for their dollar. And the performance of any intervention and the individual providing the intervention must demonstrate both value and efficiency. So as a follow-up to the article Determining the Value and Efficiency of Respiratory Care, Dean Hess had an accompanying editorial entitled Using Evidence to Adjust Productivity, Bringing Respiratory Care into the 21st Century. And I think the key takeaways from this editorial are understanding the importance of evidence-based practices and how to apply this principle in the delivery of respiratory care, and that respiratory care practitioners need to be the evidence-based practices leader with their own and extended teams. And this shouldn't just fall on managers to carry this out. The concept of practice near the top of their skill level is not a new concept, nor is stopping the repetition of menial low-level tasks poorly supported by evidence. And the beauty of this concept for the respiratory care profession is that pulmonary diagnostics should be well positioned to survive and hopefully flourish in this rapidly changing healthcare environment. Based upon published resources, we should have a high degree of confidence that evidence-based practices are employed for the vast majority of commonly performed pulmonary diagnostic procedures. However, as with many things in an evolving healthcare environment, this topic should be closely monitored to have a good understanding if and or when changes need to occur. Continuing with Technologist-Driven Protocols, why now? July was a very busy month for the American Association for Respiratory Care. And this webinar provided the metrics and application behind the article Determining the Value Efficiency of Respiratory Care. The article and editorial by Hess are must-reads, and this webinar is a must-see. The diagnostics community needs to be well-versed on this topic so that we too can survive in this changing healthcare environment. We need to rethink how we do business in an environment of perpetually rising costs and declining number of potentially qualified credentialed individuals. When there is an opening in your department and you're having difficulty filling the position, can you look outside the respiratory care pool? For example, as a credentialed professional, what diagnostic procedures can be farmed out to, say, less credentialed on-the-job training personnel? Also, what highly repetitive procedures do you offer that have their frequency be modified? How about if you can currently perform an MVV on every subject? What value does that bring versus performing the procedure with select individuals, hopefully identified using a technologist-driven protocol? What procedures, especially complex ones, do you offer but rarely perform? Can these be dropped and subjects referred to other laboratories who actually perform them on a regular basis? Such suggestions and concepts may make you uncomfortable, but think about the long-term implications and prospects if you don't potentially modify how you work. Remember, it's all about quality and not quantity. So continuing with the American Association for Respiratory Care activities in July of 2022, at the first day of the summer forum, a plenary session was occurred entitled Using Systematic Reviews and Clinical Practice Guidelines to Create Evidence-Based Practice. As you can see, there are a number of topics were included, but it's actually a re-emphasis by the AARC on the importance of using evidence-based practice in the delivery of care. And for those of you who are not familiar with the grading system of clinical recommendations, the system classifies quality of evidence, and it's reflected in confidence and estimates of effects as high, which is a grade A, a moderate level, which is grade B, or low, which is grade C, according to some factors that include the risk of bias, precision of estimates, the consistency of the results, and the directness of the evidence. The next session that was up at the AARC Summer Forum on the first day was value efficiency. Once again, that topic that was presented by Gary Kaufman, one of the principal authors of the original article, just updating participants with regards to the importance of value, efficiency, and delivery of respiratory care. Rounding out the theme on evidence-based practices at the AARC 2022 Summer Forum on the first day was a presentation entitled RT-Driven Protocols, How and Where Do I Begin? So that's it for background. I realize that I front-loaded a ton of background information for this topic, and I thank you for your patience. I simply wanted to highlight some key external and internal factors that are influencing how healthcare is evolving. Some of these factors may not be all that favorable to the respiratory care profession. However, other factors may provide opportunities for respiratory care, diagnostics included, to improve upon the delivery of care. Having a good understanding how evidence-based practices can influence care will hopefully accomplish this in a positive manner. So let's get back to the importance of technologist-driven protocols. So what we're going to do is move on to technology-driven protocols. What's the payback for diagnostics? We're going to focus specifically on technologist-driven protocols and the importance of using evidence-based practices. Once again, the source of evidence-based practices comes from the ATS, American Thoracic Society Pulmonary Function Laboratory Management and Procedure Manual, the most recent 3rd edition. Technologist-driven protocols can provide a roadmap for decision-making on the flow of testing based upon the client's diagnosis, medical history, and/or from initial pulmonary diagnostic data. They may be developed from a combination of evidence-based information and vast clinical and/or laboratory experience. And if they are well designed and validated, that's the important thing, is to be validated. They add value to your facility and to the organization by reducing procedure variability, improve the efficiency, consistency, and the quality of delivered services. Okay, as a pulmonary diagnostic technologist, you are a diagnostician and provide added value to your organization. You are trained to provide quality-driven, cost-effective services to your customers. You are viewed as a valuable resource, the go-to person and a colleague, a physician extension, and not simply a task completer to those healthcare providers that you interact with on professional matters. So ask yourself, are you a tech or a technologist? And believe me, a title and perception does matter. Think about how you introduce yourself to your colleagues and to your clients. Does your credential state that you're a certified or registered pulmonary function tech? Do your colleagues refer to you as the PF tech? Is it time to change perception and gain the recognition this profession deserves? Like discussions we've had with within the diagnostic section of the American Association for Respiratory Care, maybe it would be worthwhile to display the areas needed to know to pass the NBRC credentialing examination and refer those individuals to it so they have a better appreciation of all that goes into your practice. What I would do is I would post the pulmonary function technology examination detail content outline somewhere within the pulmonary diagnostic laboratory. Let's step out here and take a look at this clinical scenario. A 64-year-old male, an inpatient, who is a lifelong farmer, is referred for testing as part of his preoperative assessment for a right great toe amputation due to a crush injury. His past medical history is unremarkable except for a 23-year smoking history, and he quit at age 41. Now, the requested preoperative pulmonary diagnostic procedures are for complete studies. For example, spirometry with bronchodilator, MVV, airway mechanics, lung volumes, diffusing capacity, and resting room air arterial blood gases. So my first question is, what would you do in this instance? And while you're thinking about that, I'm going to throw my comments in here. If you are a tech, then you would perform the requested procedures. A technologist, on the other hand, would require additional information, more compelling information to proceed with the ordered procedures. So the next question is, how do you arrive at your conclusion that the requested procedures may be excessive? And hopefully, it's a combination of evidence-based information, vast clinical and laboratory experience, and documented and validated technologist-driven protocols can assist in decision-making. When making decisions on justifying the sequence or flow of client testing, you may have the equivalent of a technology-driven protocol flow chart in your head. However, unless the sequence is clearly documented and available for review, it's difficult to defend your position when experiencing pushback with someone who may disagree with your testing recommendations. There are a number of factors to consider during the technology-driven protocol pre-planning phase. Before you invest a lot of time and energy into developing technology-driven protocols, it's probably best to step back and assess your organization's willingness to be open to change. For example, how open do you think organization leaders would have been during the height of the SARS-CoV-2 pandemic, and you brought in a proposal to change the way you do business? Therefore, for your added reading, I've included the section Organization Readiness, which can be found in the Pulmonary Diagnostic Laboratory Resource Center under Implementation Science. Realistically, there are many individuals who are reluctant to accept change in the work environment. Going from the way we've always done this to something more formalized like a technology-driven protocol may be inconceivable by some. Therefore, it's probably worth it to develop a compelling outline focusing on the potential benefits of implementing technology-driven protocols and presenting this information to organization key decision makers, for example, your medical director and administrators. When you do this, please be patient when detailing your focused outline to these decision makers, as they may have competing priorities and, unlike you, may not immediately appreciate the importance of incorporating technology-driven protocols as a part of quality service delivery. It may be also beneficial to garner early input from laboratory co-workers. Doing so allows them to have a clear understanding of the project intentions and be part of the development process and hopefully have early buy-in to the project. Now for me, while I was at the University of Wisconsin Hospitals and Clinics, the perfect storm was occurring in the mid to late 1980s. We had managed care, capitation reimbursement models coming in, DRGs were being finalized, the quality assurance, continuous quality improvement focus, and why was everybody ordering complete pulmonary function tests? Pulmonary diagnostic testing requests were received from a variety of providers and services, not just pulmonologists. Because of this, with many providers, there appeared to be a general lack of understanding of what each test was and how to potentially apply particular test information to patient management. All these factors were my driving forces to pursue the implementation of technology-driven protocols into the delivery of quality services. After concepts and information were reviewed and okayed by the Pulmonary Quality Assurance Committee, packets of information were developed and delivered to key stakeholders, referring physicians, all Department of Medicine and Nursing offices, and all incoming medicine residents and pulmonary fellows. The purpose of this information packet was to have a common understanding of requested procedures offered by the laboratory and hopefully reduce inappropriate order of tests. The information packet included indications for testing, review of services, and testing profiles overviews. This information packet served as the validation base when outlining the flow of technology-driven protocols. After discussions with the medical director and respiratory care director regarding the intent and using the information from the pulmonary diagnostic order form, we first developed a technology-driven protocol entitled Guideline for Assessing Requests for Pulmonary Function Testing. It was based upon the subject's diagnosis or medical history and what series of testing profiles, I'll talk about those in a second, would be the most appropriate. The goal was to reduce variability and improve consistency and quality of delivered services. It was also used by the pulmonary diagnostic technologist to suggest appropriate tests or tests to requesting physicians. We initially used a Plan, Do, Check, Act cycle and later validated with the Plan, Do, Study, Act cycle during about a 6-month pilot validation process, including pulmonary diagnostic technologist feedback. Once it was okayed by the Pulmonary Quality Assurance Committee, full implementation and monitoring for about 9 months occurred. And every 2 months, there was a revalidation of the content. Along with the packet of information, a hard copy, double-sided laminated flow sheet about the size of a small index card was delivered to previously described stakeholders, residents and fellows on July 1st, 1991. So this was about an 18-month process, going back to have patience. This information was subsequently published then in the Cardiopulmonary Section Bulletin in the fall of 1991. So this is for information only, as it was developed for a specific laboratory setting, and recommendations have changed since its development. But this University of Wisconsin Hospital and Clinic's Technologist-Driven Protocol flow sheet was for the more commonly performed pulmonary diagnostic procedures from the late 1980s to early to mid 1990s, and was designed largely from published evidence-based information, initially from published literature and then amended as the AARC Cardiopulmonary Diagnostics Clinical Practice Guidelines were published. During this time period, the ATS recommendations were limited in what they addressed, mostly start test, back extrapolation, end test, and reproducibility criterion. After this technology-driven protocol flow sheet design was finalized and approved by the Pulmonary Quality Assurance, the QA committee, prior to full implementation, the technology-driven protocol was monitored and amended for approximately a year as part of the Pulmonary Diagnostic Laboratory QA CQI program. This laminated card was used by pulmonary diagnostic technologists as a quick reference guide, a visual tool, when assessing physician requests for testing and for potentially recommending different, more appropriate testing based upon the client's diagnosis and/or medical history. Since this card was distributed to most medical staff, everyone was essentially working with the same information, as the laboratory staff and medical staff also had access to the packet information containing indications for testing, review of services, testing profiles overview. Unlike then, today's electronic health record should be able to easily accommodate a laboratory-specific technology-driven protocol, making access to the necessary evidence-based information much easier. The same flowchart information from the Guideline for Assessing Requests for Pulmonary Function Testing was published in RT, the Journal for Respiratory Care Practitioners, in the June-July 1994 issue of the article entitled Bringing Quality to Pulmonary Diagnostics by Susan Blonshine and myself. While still in the planning phase, you probably want to consider what terminology you use when describing your program. The term technologist-driven protocols may be considered controversial as it implies too much onus being placed on the pulmonary diagnostic technologist. Unless technologist-driven protocol is currently utilized in your laboratory setting, an alternate term to consider would be patient-focused pulmonary diagnostic assessment plans. This term is more neutral in tone and may be more readily accepted, especially by decision makers, if you're developing and describing the initial technologist-driven protocol planning phase. Switching gears here, we're now going to look at applying healthcare process improvement concepts into the development of technologist-driven protocols. This section will briefly review some implementation science concepts and hopefully provide the necessary information regarding the importance of incorporating these concepts into the development, validation, and implementation processes that help build technologist-driven protocol program sustainability. And don't worry, there's not going to be a quiz afterwards. So, what are implementations, research and implementation science? A recently developed area of research, implementation research, and its interconnected discipline, implementation science, have been embraced and endorsed by some health-focused educators, professional societies, and organizations. By definition, implementation research is the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of healthcare. According to the definition proposed by the National Implementation Research Network, implementation science is the study of factors that influence the full and effective use of innovation in practice. Also, the National Institute of Health defines implementation science as the study of methods to promote integration of research findings and evidence into healthcare policy and practice. Therefore, for this purpose, implementation science may be considered to be the structured link between translational research and evidence-based medicine, clinical practice, interventions, and outcomes. A major implementation science stipulation is an intervention will not succeed if it's not implemented properly, even if it's been shown to be effective in research. So for that reason, with the goal of improving the quality of health care, implementation science complements and enhances the transition from focusing primarily on quality improvement QI initiatives. Additionally, numerous healthcare professional organizations such as nursing, neurology, psychiatry are encouraging their members to be more proficient in understanding implementation science principles and applying them in practice. The primary intent is to improve the quality of delivered patients' care. For example, the ATS has recently published a position paper on implementation science. In my opinion, the AARC is way behind other healthcare organizations regarding implementation science. So what I'm going to do now is focus on some implementation science concepts and see how you can apply this information into not only everyday laboratory experience, but also into everyday life. Applying quality-focused implementation concepts into technology-driven protocol development and evaluation processes is critical for successful implementation and program sustainability. One such area that's commonly used, not only in the laboratory environment, but also in everyday life, is the Plan, Do, Study, Act, the PDSA cycle. As you can see here, this is a continuous cycle of planning, doing, studying, and acting on a specific topic. The Plan, Do, Study, Act cycle has long been used in the pulmonary diagnostic laboratory as a quality initiative. Let's talk about a generic instrument calibration using the PDSA cycle. Okay, so for our plan, P, it's going to be spirometer calibration. Our Do, D, you power on the system, you introduce the appropriate information in the calibration program, you do a quick calibration syringe leak test, you introduce the calibration syringe volume at various emptying and filling rates from low to high. You study, S, assess recovered volumes. Do they fall within previously established acceptable ranges? Act, A, use the spirometer if the calibration values are acceptable, or troubleshoot the source or sources of error and reinitiate the PDSA cycle. Think how often you use the PDSA cycle in everyday life. What about before you go grocery shopping? Or what about before you fill up your car with gas? So let's take a little closer look at what are some of the components of the Plan, Do, Study, Act cycle. The Plan, Do, Study, Act cycle was also developed by W. Edwards Deming, and it's a process planning progression that, because of its design, continuously involves the user to document, collect, and evaluate data against the original proposal, the plan. Unlike the PDCA cycle, this cycle methodology additionally allows for the option of abandoning the proposed plan if the collected data do not support the original prediction, the plan. So to differentiate from the PDCA cycle, some key components of the PDSA cycle include Plan, P, plan the test, including a plan for collecting data. Do, D, run the test on a small scale. Study, S, analyze the results and compare them to your predictions. Act, A, based on what you learned from the test, plan for your next step. Number 1, adapt, adopt, or abandon. And secondly, prepare for the plan for the next PDSA cycle. Additionally, unlike the PDCA cycle, the PDSA cycle involves all staff in assessing problems and suggesting and testing potential solutions. This inclusive approach increases the likelihood that staff will embrace the change or changes that is key requirement for successful quality improvement. So this information suggests some potential steps to use when applying the PDSA cycle to the technologist-driven protocol development, implementation, monitoring, and action phases. And just a quick note that this information is not all-encompassing, and additional actions may be needed as part of your specific laboratory services technologist-driven protocol development process. If you take a look at some of the initial stages that are required under the plan area you have to determine what the intent or the focus of the technology-driven protocol actually is, and what do you want to be accomplished. Under the D part, the do part, you have to gather supporting documentation. This is, once again, supporting documentation in the form of evidence-based practices. On the study area, what I would highly recommend is that you initiate a limited pilot program prior to full implementation to make sure that you're on the right course. And then under the ACT area, modify your strategy flow as needed. So under the technology-driven protocol development process, data suggests that quality initiatives are generally more successful if they are developed using a team-based approach versus a top-down approach. Once again, going back to thinking the difference between the PDSA versus the PDCA cycles. And the technology-driven protocol development process is consistent with this thinking. The rationale is the more understanding that decision makers have regarding the development and implementation of technology-driven protocols, the more likely that they will be supportive of the initiative. This doesn't mean that all team members need to be involved with every single aspect of the technology-driven protocol development. However, all team members do need to be regularly appraised of TDP progress, be it positive or negative. By keeping them in the loop, they will be part of the process and the solution if additional guidance is needed, especially if roadblocks are encountered. Continuing with the TDP development process, while not comprehensive, the following is a potential listing and role of some technologist-driven protocol team members. Organization administration. They need to understand the intentions of the project, which is to elevate the quality of delivered services and potentially reduce institutional costs. The Pulmonary Diagnostic Laboratory Medical Director. This is the laboratory ambassador who will support the initiative with other healthcare providers. They will also be the go-to person for potential physician one-on-one discussions if there's pushback. Ideally, you would have organization administration and the Pulmonary Diagnostic Laboratory Medical Director sitting down at the same table when you're detailing the technologist-driven protocol proposal. Representation from the Department of Quality. They have a good understanding of process development and implementation and would be an excellent resource. Nursing personnel are also important because they potentially need to interface with clients and provide a brief description of what pulmonary diagnostic laboratory testing procedures are all about. And finally, pulmonary diagnostic technologists are absolutely necessary to be active participants of the entire process. They're the ones who will be the technology-driven protocol implementers and ultimately the end users. Active participation regarding input and decision-making should enhance pulmonary diagnostic technologists' buy-in and embrace and own the project. Regarding the importance of technology-driven protocols, the take-home message is well-designed, evidence and expert opinion-based technology-driven protocols can improve the quality of delivered services by standardizing the approach to client evaluation, reducing inappropriate testing, improve the client-patient experience, as well as providing value to the organization. So this next section, we're going to be looking at some flow charts on technology-driven protocols that I accessed from the American Association for Respiratory Care Diagnostics section library. And as you look through these, I want you to ask yourself, do these work? And if they do, why do they work? And if they don't, why don't they work? Now, depending upon what needs to be accomplished, respiratory therapist-driven protocols are oftentimes single procedure focused. Therefore, using implementation science strategies, a linear flow format, similar to a policy and procedure format, could effectively incorporate the plan, P, implement, I, E, evaluate, the PI cycle, and getting to objectives, the GTOs, 10 steps into quality-focused implementation plan strategy. However, depending upon the results of initial testing, diagnosis, or medical history, technologist-driven protocols for pulmonary diagnostics may rely on incorporating numerous procedures to reach the end result. Therefore, technologist-driven protocol flow sheets appear to be most effective using a branching decision tree format. This branching tree decision format is what I subsequently used as guidance and to provide consistency for the technologist-driven protocols that were developed, implemented, and monitored in the early to mid-1990s while I was still at the University of Wisconsin hospitals and clinics. These technologist-driven protocol decision trees were used primarily as a visual roadmap to quickly determine what initial and next steps should be regarding testing. They were developed only after extensive documentation was established that provided the evidence-based information regarding the flow of testing. For technologist-driven protocol development, a flow chart is not always necessary, but processes with clear documentation are absolutely necessary. So this is the first flow chart that I pulled up from the Diagnostics section library. And you can see that it's labeled Technologist-Driven Protocol for Complete Pulmonary Function Testing with Bronchodilator. And hopefully this is large enough where you can see it okay and make it out. And if you want to pause right here to take a look at what the content may be, I highly recommend that. As you can see at the top, it starts out with spirometry. First step is if you have an abnormal MVV, what's your next step from there? Second step is if you have a normal flow volume loop or a physician requested TLC, that's your next step. And it goes on from there, and it gives kind of a branching logic to it. What I think is important on this one is patient assessment. Did the patient comply with pre-test instructions, etc.? Okay, and you go all down the line. Finally, you come to PFT testing complete. So this is the second protocol that I pulled up from the Diagnostics section library, and it's entitled the PFT/ABG protocol. And what I like about this branching setup is that it starts out with the indications for PFTs are met. So it'll go through the branching protocol, and it'll give you some, if you look at the key on the bottom part of here, it talks about what the diagnosis is as well as what the test should be. So if you want to pause and just take a look at this, and then we can go on from there. And ask yourself this question: do these work for you? If they do, why? If they don't, why not? Well, for me, the flow charts by themselves did not work. Where are the process documentation and references from the previous flow chart examples? Well-designed, validated, evidence and expert opinion-based technology-driven protocols can improve the quality of delivered services by standardizing the approach to client evaluation, reduce inappropriate testing, improve the client-patient experience, potentially optimize costs to the payer and the institution, and provide value to the organization. Flowchart development should be the last piece of the puzzle since it's based upon what has been previously documented in the technology-driven protocol. In my opinion, it's perfectly acceptable to use another laboratory technology-driven protocol flowchart as a guide as you develop your own, but you should not try and fit what you offer into a format developed by another laboratory, as their level of service may be different than what you offer. Finally, as I previously stated, a technologist-driven protocol flowchart is not always necessary. However, compared to combing through a technology-driven protocol document, a flowchart does act as a quick visual aid when determining next steps. So my final thoughts on technologist-driven protocols is that they're a method to standardize the approach to detecting and quantifying lung dysfunction. Ideally, they're developed from a body of evidence-based scientific literature. In the absence of scientific data to support specific concepts, an expert opinion may be substituted, but that limitation has to be recognized. Implementing well-designed and validated pulmonary diagnostic technologist-driven protocols should improve the efficiency, consistency, and the quality of delivered services. Also, technology-driven protocols are consistent with current AARC directive. And finally, in my opinion, it's imperative to provide the rationale behind technologist-driven protocol development. Simply developing a flowchart without supporting documentation is only part of the picture and subject to criticism regarding the validity of the technologist-driven protocol. Hopefully, this overview has been of assistance as you develop and/or modify your technologist-driven protocols. Remember that this is a process and not a race. Also, there may be more than one iteration of the protocol before being suitable for full implementation. Incorporating implementation science concepts into the development, evaluation, and execution of technologist-driven protocols should be the keys to success to providing a viable and sustainable program. In the U.S., enormous sums of resources are expended each year in healthcare, with oftentimes less than optimal return on investment. In an effort to improve upon the delivery of care since the late 20th century, focus was placed on healthcare quality improvement, which has been met with mixed success. Utilization of process concepts that were designed for industry has been less than optimal in a fluid, dynamic environment such as healthcare. Undertaking change can oftentimes be perceived as a daunting challenge, even if evidence suggests that the change is necessary. Having a clear understanding of potential quality improvement processes can assist the pulmonary diagnostician in successfully designing, implementing, measuring, and instituting new programs or modifications to existing programs. Implementation science principles and how they are intimately linked with healthcare quality programs should enable the pulmonary diagnostician with developing processes that improve sustained delivery of quality care utilizing technologist-driven protocols. Understanding organization readiness for change is paramount prior to even considering designing an improvement project and/or instituting a new program. Such an understanding reduces program development time wasted and overall frustration in trying to implement a program that may not be perceived as valuable. Some healthcare organizations have advocated for their members to embrace and enact respiratory care-driven protocols and implementation science principles as part of their scope of practice. Now is the time for the field of pulmonary diagnostics to follow their colleagues' example to improve healthcare quality by adopting a focus on developing, monitoring, and implementing validated technology-driven protocols. The healthcare environment is evolving and placing more emphasis on quality and payer return on investment. Technologist-driven protocols may be an answer to successfully addressing both of these issues. The next couple of slides list some suggested references. The first two listed here, the ATS Pulmonary Function Laboratory Management Procedure Manual. That is absolutely necessary for part of your library and to use as a source of evidence-based practices, because this manual contains the referenced indications and contraindications for each of the procedures that's listed. And for those of you interested, I suggest you go back and revisit the AARC Diagnostic Clinical Practice Guidelines to look at the body of scientific literature that was used to support the published clinical practice guidelines. And that link can be found at the bottom of this page. So here are some additional resources that I would highly recommend if you want to move forward with the technologist-driven protocol program. The first one, Pulmonary Diagnostic Laboratory Resource Center, contains three areas which will be helpful for you as you develop your program. Also, I highly recommend the Institute for Healthcare Improvement, the IHI websites. They have a ton of free resources that you can use as you develop your quality improvement projects, as well as your technologist-driven protocol program. So again, want to thank you for taking time out of your busy schedule to listen to this presentation. And like I stated at the beginning, if you do have comments or questions, please go to the Pulmonary Diagnostic Laboratory Resource Center at www.pftlabresources.com. Click on the contact section and send me an email with regards to your comments and questions. Thanks so much and take care.